Hello and welcome to the latest episode of PYA's Healthcare Regulatory Roundup webinar series. Today's topic is Fiscal Year 2024 Final Rules, getting ready for October 1st. PYA is happy to present today's webinar on this important topic. You can submit questions during the webinar by typing a message into the questions pane of the control panel. Also, immediately following the end of the webinar, you'll be asked to complete a short survey and submit any additional questions. We'll respond to questions posed after the webinar via email. We've posted in the handouts pane of the control panel a PDF copy of the slides for your reference. Also, you'll receive an email later today with a copy of these slides and a recording of this webinar. With that, I'd like to introduce our presenters today, Martie Ross and Kathy Reep.
Good morning. Glad to have you with us this morning as we talk about all the final rules that we have suddenly gotten for the that are effective October 1, 2023. These are the fiscal year 2024 rules. We're going to go through a number of them today: the inpatient prospective payment system, the inpatient rehab, inpatient psych, skilled nursing, and then the infamous hospice wage index and payment rate update. Since hospice isn't really a prospective payment system. So let's kick it off with the hospital inpatient PPS rule. The way we're going to kind of tag team this one today is I'm going to go through the finance side, Martie is going to go through the quality and the value-based payment side of each of these various programs. So kicking it off with the inpatient prospective payment system. The rule was actually released on August 1st, but it won't be in the Federal Register until August 28th, if you've been looking for it. From a payment perspective, we have gotten a slight increase over what was originally proposed. The proposed rule called for a 2.8% increase, but what we actually see in the final rule is a 3.1% increase. However, if you talk to just about anyone, the 3.1 is not good enough in terms of the impact right now of increasing costs on providers and the increasing cost of care. The way the update was calculated is a market basket update of 3.3% less 0.2 percentage points for productivity. And that leaves us with a standardized rate of about $6,500, a little bit greater than the $6,375 that we have now. Recognize that for those hospitals that are not meaningful users of electronic health records, the update will be less. We'll go through that in just a minute. The capital rate also increased from $484 to about $504. And there is a significant, I think, increase in the outlier threshold from the current $39,000 to almost $43,000. So this will make it harder for a case to be considered an outlier in fiscal year 2024. On the next slide, you can see the breakdown from a payment perspective, depending upon whether you are urban, whether you are a hospital with a wage index greater than 1 or less than 1. On this particular slide, the table 1B is going to be those hospitals with a wage index less than 1. And for those hospitals, 62% of their payment rate is adjusted for labor. For those with a wage index greater than 1, 67.6% of their payment rate is adjusted for labor. You can see that in the first box on each of these, it shows you what your update is going to be, labor and non-labor. If you are both, you submit and are compliant with the requirements for quality data and are a meaningful user, but you can then see what happens if you are not a meaningful user of electronic health records or not appropriately reporting your quality information. The payment rates go down significantly. To the point, if you are neither a meaningful user of electronic health records, nor do you submit your quality data, you actually wind up with a negative update for fiscal year 2024. Now, the American Hospital Association, the Federation, America's Essential Hospitals, the AAMC, all of them have reached out to Congress with arguing that the 3.1% increase is not enough. We will see what we might get out of Congress between now and the end of the year. I guess I would turn to Martie and say, any chance?
It's going to be an interesting September, Kathy. That's all I'll say.
Well, and it's also one of those, be careful what you ask for because you might get it, but then it's how you pay for it.
Exactly. Or how long you'll pay for it, or who else are you going to be fighting over the carcass with, right?
That's true. Ooh, carcass. All right, let's look at the changes for the MSDRGs and the relative weights. For this year, they are going to use a single year of data to set the weights. There will be no modifications for COVID-19 that like they did last year. They're going to use fiscal year 2022 MedPAR claims data and 21 cost reports. The issue on this is if you think about how have your costs changed since fiscal year 2021, using this older data is going to have a definite impact on the weights and the costs of care that you should be seeing. Because of some changes to the DRG classifications, there will be a number of adjustments to the post-acute transfer policy. For those who are not familiar with this particular policy, under the post-acute program, if a patient is discharged from the acute care hospital to post-acute care, other than to a swing bed, there is a reduction in the DRG payment if the patient did not stay for the full length of stay associated with that DRG. Because of some changes to the DRGs, we're going to see 5 new DRGs added to the post-acute transfer policy, but we're also going to see 13 MSDRGs that will be removed from that policy. Something that I urge you to take a look at the patients that you are treating and whether or not those services that you're providing will continue to be subject to the post-acute transfer policy or not. There are also a number of new MSDRGs that have been added. Again, 15 new DRGs, but at the same time, we're losing 16. So major shift here in terms of the DRG volume. As was proposed in the inpatient, in the proposed rule, we're seeing our first adjustment to claims because of using the Z codes to report issues related to the social determinants of health. This is going to be the first adjustment that we've seen from a severity level designation if you use the appropriate Z codes for homelessness. If you are admitting a patient or treating a patient in your hospital that you have coded on the claim as being homeless, you will see that there will be a bump in your reimbursement because coding the claim using the codes that I've listed there, the Z59, Z5901, Z5902, that will move the claim from a non-CC MSDRG to a CC. Using the final rule, it gives you an idea as to the impact on reimbursement. Remember, you multiply your DRG weight by a labor adjusted rate. And so previously, when homelessness was not considered a severity adjustment, the weight that would have been assigned for simple pneumonia and pleurisy, they would have gone into DRG 195 with a weight of about 0.63. Moving this into a complication comorbidity, you're now going to be looking at DRG 194 with a weight of 0.82. So a good bump in your reimbursement for these particular cases.
And some significant discussion in the final rule regarding plans for similar adjustments in future years as CMS begins to receive additional data regarding Z codes. So remember, last year at this time, we were talking about new reporting requirements under the inpatient quality reporting program relating to screening of patients for the 5 core social determinants of health. As you're screening that data and accumulating it, it's critical that it makes its way to claims data as Z codes, so that data is then available to CMS to track the impact of these SDOHs on the cost associated with providing care. I mean, homelessness is a pretty straight line explanation. If a person doesn't have a stable environment in which to recover, you can anticipate the expense is going to be greater to care for that patient during the inpatient stay. But let's see what happens in terms of food insecurity, in terms of transportation, and those other core SDOHs, which we're now tracking that data to meet our IQR requirement and getting it translated to the Z codes on the claims.
Thanks, Marty. On the next slide, we've got an update on the new COVID-19 treatments add-on payment. We are familiar with the fact that at the end of fiscal year 2023, the end of September, that add-on payment will expire and that there will be no additional payment for the new COVID-19 treatments as of October 1, 2023. That would be the beginning of fiscal year 24. We also have had for a number of years under the Medicare inpatient program, new technology add-on payments. This is essentially when there is a new way to deliver care, a new type of technology that is being used. And for a period of time, you have been able to receive an increase in your reimbursement if you are using this new technology. Again, proper coding is what got you that additional payment. Because a number of services that previously had received the new technology add-on payments have expired. Their time period has expired. We're seeing a significant drop in the actual payments that will be made for new technology add-ons. We're looking at about a $364 million decrease in payments. And under the final rule, we're going to see 11 new technologies still being considered new, but there are 15 technologies that will no longer be considered new. You need to take a look at what you currently are providing and recognize whether those services continue to be considered new technology or not. And then as proposed, CMS has also finalized the policy that would require the NTAP applicants who do not currently have FDA authorization to actually have a complete and active FDA market authorization application, at least in process by the time they submit the request for to be considered a new technology for add-on payments. And then they also moved the FDA approval deadline from July 1 to May 1, beginning with 2025. A rather sensitive issue in terms of the reimbursement, getting a lot of media and even congressional attention, relates to Medicare disproportionate share. You're familiar with the fact that the disproportionate share formula is Medicare SSI days divided by total Medicare days. Added to that would be your Medicaid non-Medicare days divided by total patient days. So that's the formula we've been dealing with for a long period of time. Well, in the proposed rule, CMS said that they were expecting to only reduce the uncompensated care pool by about $115 million. Final rule comes out, and all of a sudden they are reducing the pool by $967 million, significantly greater reduction than was proposed. So the pool is now going to be $5.9 billion, where it has been $6.7. CMS uses as their citation for making this adjustment information from the CMS Office of the Actuary that says that the uninsured rate in 2024 will be 8.3%. Currently in 2023, we're dealing with 9.2%. But the issue that comes into play with this is we're dealing across all of the states with a large number of Medicaid redeterminations. And as the states go through and make a redetermination as to whether an individual continues to qualify for Medicaid, we've got other agencies, not the CMS Office of the Actuary, but let's take a look at the Congressional Budget Office. And the CBO says that the uninsured rate is probably going to increase increase to 10.1% by 2033. So they are saying the uninsured rate is going up, whereas the information from the CMS Office of the Actuary is that the uninsured rate is going down. Concerned with this particular, because this is going to be a major hit for a large number of hospitals to have this reduction in the pool. Meanwhile, they are still treating these uninsured individuals coming in 2024. So again, the question is, will Congress step in? We're not sure, but there has definitely been a lot of ask on the part of a number of associations. The other provision that they looked at as it relates to disproportionate share is the calculation of Medicaid 1115 waiver demonstration days, and whether or not these days are going to count in determining your Medicaid non-Medicare days. And so the issue is, they have said that they are only going to count those patients that are covered by the waiver, covered by a waiver that provides either insurance covering inpatient care, or they have a fully a fully subsidized premium assistance to allow the purchase of such insurance. The problem is, we have a number of states that do not fully subsidize the premium assistance. They partially subsidize premium assistance. And therefore, the way they are implementing this policy, there are a number of states, not just those that had an uncompensated care pool, like Florida and I believe Kansas and Tennessee, Texas, not just those states will be penalized, but additional states that do not fully subsidize the premium assistance for individuals to purchase insurance. So this will be make a significant impact on the calculation of your disproportionate days moving forward.
And Kathy, we would be remiss to talk about Medicare DSH without reminding everyone of the impending cuts to Medicaid DSH, absent congressional action. We're looking at billions of dollars in reductions in those payments, absent Congress stepping in again, and either delaying or finally reversing those cuts.
And that would be effective October 1, those cuts?
Of next year, right?
Oh, yeah.
Right, we have one more year they gave us in the last okay. mega Consolidated Appropriations Act. So we could take a little bit of a breath, but it's something we can't lose track of. It's sort of right there with the sequestration delays that have been pushing things back a little bit further, but eventually the piper will want to be paid.
Well, and we're asking for a lot of things. The wage index policies, again, they pretty much stuck with what they had proposed. I think throughout this rule, they stuck with what they proposed. But as we had addressed when we went through a webinar on the proposed rule, they are maintaining the low wage index hospital policy. Those would be those hospitals in the lowest quartile of wage indices across the country. This went to court, CMS lost, but CMS did say that they are appealing the decision and they're going to stick with this adjustment. Those hospitals that are in the bottom quartile, those with a wage index below 0.8667, have their wage index brought up halfway between the wage index value and their actual wage index value and that 25th percentile. So there is adjustment that is being made there. The issue and why this went to court was because the policy was applied in a budget neutral manner, and therefore while these hospitals get a bump, all hospitals got a reduction in their standardized amount. So you wind up having hospitals with a bump in the wage index, but a reduction in their standardized amount. And that is a concern in terms of whether CMS should have done this. The initial court decision was no, but as I said, CMS is appealing that, but they're keeping it in place while they appeal. The other issue that it seems to have a major impact on a number of providers, or actually I guess I should say markets, is CMS, as proposed, is going to treat those rural hospitals, reclassified rural hospitals, as if they are geographically rural for the purpose of the rural wage index. So in order to actually calculate your wage index, if you are a hospital in an urban area that has reclassified as rural, you meet the criteria and therefore you're reclassified, your wage index, which is perhaps higher than most rural, will be included in the calculation of the rural wage index. Then go back and remember that a urban area cannot have a wage index that is less than the statewide rural wage index. Therefore, we suddenly are seeing areas, urban areas with a low wage index being raised up to the statewide rural because it's greater than they are now that we've got these reclassified hospitals, the urbans reclassifying as rural. So across the country, we're seeing significant impacts for a number of providers who are suddenly seeing a bump in their wage index that will be used for the calculation of the payments in 2024. This is another one of those issues that it makes a lot of winners across the country and some losers, but I am concerned that what will ultimately happen in terms of addressing the overall wage index policy. The MedPAC, the Medicare Payment Advisory Commission, has said you need to go back and restart at square one for determining the wage index. This gives them more fodder based upon the number of hospitals that will have wage indices that are not their true wage index.
It's important to keep in mind, market basket update's the only place where we grow the pie. That we look at historical inflation, and the formula in the statute tells you increase the expenditures on hospital inpatient by X. So that's how you grow the pie. The wage index is just about how the pie gets divided up. So it is always a matter of winners or losers. So as you're saying, yes, there are some urban areas that will see the benefit of reclassification to rural, but that means that somewhere else there's someone that is being disadvantaged by that.
Absolutely.
It's always sort of, it's the match between the hospitals as opposed to trying to grow the pie overall.
One of those things that we always see when we get the inpatient proposed and final rule is the long-term acute care hospital PPS rule as well. So that's always included with the inpatient rule. Let me touch very quickly on the payment update for LTACs. They are going to receive a 3.3% increase in their payments over fiscal year 2023. Remember that inpatient acute care hospitals are going to see a 3.1% increase in that same time period. Again, the same formula. We're looking at it should be a market basket of 3.5 less 0.2. So I apologize for that typo on the slide. The labor share is going to go up a little bit. So if you have a wage index greater than 1, it's going to further increase your payment. The cost outlier threshold going to be a significant hit here for long-term acute care hospitals. Currently, your cost outlier threshold is about $39,000. It's going to go up to almost $60,000. The one thing to be thankful for, I guess, is that the proposed rule was closer to $98,000 for that threshold. So it's still going to be a big hit. You're going to have a lot more claims that will not hit an outlier threshold, but it's not as bad as it was proposed to be. The reason for this huge jump is because the law does require that the outlier payments be about 7.9% of total payments. So in order to meet that threshold, we are looking at this huge jump in the cost outlier threshold. And just to give you the final numbers on the long-term PPS payment update before I turn it over to Martie, the 3.3% increase in your rate will give you a payment rate of about $48,000. If you are not a meaningful user of electronic health records, then we're looking more at $47,000. So Martie, a little bit about quality.
Let's talk about all of our other programs that are part of IPS each year, beginning with the inpatient quality reporting program. Here, Kathy, here's one that'll make you feel old. IQR is celebrating its 20th anniversary this year. It was introduced, I know, it was introduced into IPS with the Medicare Modernization Act of 2003. So this is sort of the original value-based purchasing program in Medicare. But the intention was, let's reward hospitals, actually avoid punishing hospitals that collect quality data and report that, which then can be made available to the general public in selecting an appropriate hospital to receive services. So the fact that you can have the exact same service delivered by the very best hospital and the very worst hospital, it gets paid the same amount. This was beginning of the process of creating some sort of differentiation in payment based on the quality of care furnished by a hospital. So IQR is a combination of different types of measures that are reported at different points of the year and different quantities. Certainly, I'm sure at your PPS hospitals, you have folks that are well familiar with these reporting requirements. This year for FY2024, it's more of the typical nibbling around the edges adjustments to the IQR program. That starts with the addition of new ECQM measures. You see the 3 additional measures that will be added beginning in the calendar year 2025 reporting period, so not next year, but the year after. Remember, for ECQM, there are roughly a dozen measures from which you select 4. Actually, you only select 3 because you're required to report on the safe use of opioid measure, ECQM. But so this is simply broadening out the number of measures from which you can select to report for ECQM purposes. There are then adjustments that CMS is making to several measures that are included in IQR, including the 2 hybrid hospital measures on which you report, as well as a change to the COVID-19 vaccination among healthcare personnel measure. And this is going to be a common theme through all the QR programs we're going to talk about today. The current language of that measure refers to complete vaccination course, and we're changing that language to up to date, meaning that the healthcare personnel have received the COVID-19 vaccinations consistent with then current CDC regulations. So this is intended to make the measure meaningful going forward as evidence develops on the COVID-19 vaccination. So we're trying to move just away from who's completed initial round of vaccinations to in fact being current with CDC recommendations. We'll then also have removal of 3 measures you see specified there, so they will no longer be reported beginning in calendar year 2024. And then finally, some changes made to the submission process, broadening out how we can collect HCAHPS measures, being able to do that electronically, and changing the dates on which HCAHPS surveys are circulated. Also changing some validation measures due to extraordinary circumstances, sort of that tail end of public health emergencies, the adjustments we make to account for those hospitals that aren't included in the pool because of extraordinary circumstances. From the oops, my fault there. Remember, if you do not report, as Kathy noted, if you do not report your quality data, if you do not cross all the T's and dot all the I's for the program, then you're going to see a reduction in your market basket adjustment. And so recently reported, CMS released the data indicating that for FY2024, we'll have 95 hospitals across the country, 95 PPS hospitals that will be penalized because they did not meet their IQR requirements in FY2022. Remember, report 2 years later is the payment adjustment. Promoting interoperability program, also, if you do not report your data for PI, you're also subject to a reduction in your market basket update. The more significant adjustment is associated with PI. Again, very routine adjustments made in this year's IPS, such as defining the reporting period, requiring that you report yes to the SAFER guides, as opposed to just simply indicating that what you do currently is acknowledge the guides. Now you have to affirmatively state, yes, we meet the requirements. And then similar to the IQR program where we added those new ECQM measures, the same occurs here in the PI program. Again, in 2024, we're going to see more hospitals, 164, that are going to be penalized for failing to meet their PI requirements in FY22. Now let's shift gears from the programs that adjust your market basket rate to those that are more engaged, more directly impacting the payments that you received overall. That starts with the hospital readmission reduction program, one of the 3 value-based purchasing programs within the inpatient prospective payment system. The hospital readmission reduction program penalizes hospitals with higher readmission rates. For example, CMS believes this year and upcoming year in 24, about 2,900 PPS hospitals are going to be penalized because of their higher readmission rates in 2022. And in fact, the hospital readmission reduction program has the most significant impact on hospitals as compared to all the other value-based purchasing programs. Here, what we're doing is simply comparing your rate of 30-day risk adjustment standardized unplanned readmissions to hospitals that have a similar proportion of dual eligible beneficiaries. So this and the readmission reduction program is the first time we saw a health equity related adjustment. So rather than comparing you to all hospitals and what your readmission rate is, we're instead going to compare you to those hospitals that have a similar proportion of dual eligible beneficiaries. We use that as an effective measure of the type of patients that you provide care for and group you accordingly in 5 different categories. No proposed changes this year to any of the conditions or procedures that are part of the calculation, nor any changes to the methodology for calculating readmission rates or imposing penalties. So in fact, the program has stabilized at this point in time. And in fact, in the final rule, CMS anticipates that this program is going to move forward in a very similar method until such time they start identifying top-out measures so that the readmission rates are pretty consistent across all hospitals. That's the point in time they would make adjustments to the program.
Martie, just one thing on that is that the adjustment for the readmissions program is 3% of a 3% reduction in the base rate. It's before it has actually been multiplied by the DRG weight, et cetera. It's in your base rate where this adjustment comes into play.
And it's dollars that just come out and are reinvested back into the program. So it's not a budget neutral program. It's actually a negative impact on providers across the board. Unlike the second of the value-based purchasing programs, aptly named the hospital value-based purchasing program, this is a Robin Hood approach to value-based purchasing because CMS withholds from all hospitals across the board 2% of their base rate, and then is going to redistribute that money to the top performers. So in effect, you can at one end of the scale get a 2% bonus payment. At the other end of the scale, if you do not qualify, you're not going to be repaid any of that 2% that was withheld from you. So you have the opportunity to get your 2% back plus 2%, up to 2% more, or you just lose your 2%. So that's what this program, that's how this program operates. Beginning in the FY26 program year, CMS will be adopting the updated severe septic shock bundle that has been reported under hospital IQR program since FY2016. So no significant change here. It's just now your actual performance on this measure is now going to become a component of the value-based purchasing program. The most significant change in the VBP program is this introduction of the health equity adjustment. So similar to what we're doing in the readmissions program, where we compare you to similar hospitals, here we're going to make an adjustment to your score based on both how well you perform across the relevant measures, but also that proportion of individuals you treat that have dual eligible status. Again, dual eligibility, an individual who qualifies for Medicare but also for Medicaid, that's become the metric we utilize to identify safety net hospitals in effect, because we assume if you are treating a higher number of those patients that you have, in fact, treating patients with a lower socioeconomic class, more challenging patients. So we're going to reward you by adding bonus points to your value-based purchasing score, making it more likely that you're going to receive dollars back. Of course, again, this is a Robin Hood program, meaning if we're going to give more money to the hospitals that take care of these dual eligible beneficiaries, we're going to give less money to those hospitals that are treating regular Medicare beneficiaries. So it's the balance between the two. There are also several other minor modifications that are going to impact later program years. BBP is always one where CMS gives us lots of warning on the changes it's going to make to the program because of the complications in the calculation. Remember, this is always a matter of your performance in year one impacts your payments in year three, because there's that time required to collect the data, to compare the data, to calculate the rates. And so it's always 2 years out that we make the changes. Finally, our third value-based program in IPPS is the Hospital Acquired Condition, or my favorite acronym, the HAC Reduction Program. This is a penalty that is imposed on those hospitals in the worst performing quartile. So we take, as you can see, a list of hospital acquired conditions. We calculate the hospital's rate across those measures, and then we take the scores and put them in quartiles. And if you find yourself in the worst performing quartile, then it's a 1% penalty on your base rate. So this one is, again, like the hospital readmission program, is a savings to the Medicare program on the assumption that those hospitals that experience higher rates of HACs are going to be more costly to the program, and so we're going to retain those dollars. CMS is adding this year a validation reconsideration process, similar to the one that has been in place for the inpatient quality reporting program for a number of years. So this is your opportunity now to challenge the determination of your HAC rate and the fact you end up in a particular quartile as a result of that. They're also going to make some, again, adjustments to the validation mechanisms based on the number of hospitals that claimed extraordinary circumstances exemption.
Marty, where I mentioned that for the readmissions reduction program, it was a reduction to your base rate. For the HAC program, it is a reduction to your entire payment amount. So if the claim happens to be an outlier, you're going to see that 1% reduction, not only on the DRG payment, but on the outlier payment, on disproportionate share, on medical education, anything that was included on that claim that you are billing for, you're going to see a reduction of 1%. So when they wrote this one, it was really the last provision, the last value-based payment type system that they put in place, and they said adjustment to the payment as opposed to adjustment to the rate. So unfortunately, it carries a huge penalty financially if you wind up having a HAC penalty.
Other issues in the IPS rule, and again, it's a pretty quiet rule this year, certainly some controversial provisions, but certainly not wide-ranging. CMS is adding GME payments for rural emergency hospitals. All 6 of them, I think, is how many we've converted so far this year. Changes to the process for a physician-owned hospital to receive an exception on the expansion prohibition. So this is physician-owned hospitals that serve a high percentage of Medicaid patients, the process that they can request the opportunity to expand their operations. It's more limiting provision there within the Stark law. Changes to the long-term care hospital quality reporting program in the upcoming years, as well as for PPS exempt cancer hospital reporting programs as well. So Kathy, let's talk about IRFs.
Yes, inpatient rehab facility PPS. The rule for the inpatient rehab came out on August 2nd. This was actually publication in the Federal Register as opposed to the posting date of August 1st. So it was posted, if I remember correctly, somewhere
July 27th?
Something like that, late July, yes. So going on, let's look at the payment update as they relate to inpatient rehab. Okay, remember I said 3.1% increase for inpatient acute, 3.3% for long-term acute care, and for the inpatient rehab facilities, we're looking at a 4% increase in the payment rate for over what we have in 23. The main reason for this adjustment is the outlier threshold, and it is an adjustment to the outlier threshold. It's an add-on, whereas inpatient skilled nursing has a reduction that we'll see in a little bit. That is an adjustment, negative adjustment for the outlier threshold. But it is a market basket update of 3.6%, less 0.2 percentage points for productivity, and then 0.6 for the change in the outlier threshold. Your payment rate is going to go up to about 18.5 compared to the current 18.8. And the outlier threshold, you can see the decrease there. It is currently $12,500. It's going to go down almost $2,000 or a little over $2,000 for 2024. They did use 2021 claims to rebase the market basket. Again, older claims, so a lot of the costs that you're incurring now perhaps are not in this. The labor share is going to go up to 74.1% from close to 73. And this is two things on this. First of all, the reason that they are saying that they are increasing the labor-related share is tied to the issue of contract labor and the need to use additional contract labor for inpatient rehab. I'm not sure that that's the only place that we use contract labor, but that is one of the reasons for the bump in the labor-related share. Again, as was with the inpatient acute, if you are a hospital with a wage index greater than 1, this means you're going to see an increase in your overall payments. If you're a hospital with a wage index less than 1, your overall payments will ultimately go down as a result of this adjustment. And then we're going to see this both for rehab and for inpatient psych PPS, but rather than having the proposal that, or the rule that we have now that only allows you to open or to claim for Medicare purposes one of these excluded units at the beginning of a cost reporting period, they are now going to allow you to open and claim for Medicare purposes an excluded unit at any time during the year, as long as you give your Medicare administrative contractor at least 30 days notice of the opening. So,
oh, thank goodness. Been down that road a few times. Yeah, exactly.
Yeah.
Finally making sense with that rule. Inpatient rehab quality reporting program, again, operates similarly to the IPPS program. And similar measure adjustments made this year. As I said previously, we're going to do those adjustments to the COVID vaccination for healthcare personnel. Again, changing it from complete vaccination course to up to date. For FY2025, we're going to see the addition of one measure and the removal of 3. Now, IRF QRP works a little differently because most of the data points are derived from the IRF patient assessment instrument, that the IRF collects data at admission and discharge of the beneficiary and then submits that information to CMS. And information is derived from those assessments for purposes of calculating the different measures used within QRP. So the quality of reporting within this program is really the completion of the assessment instruments and their submission. And so you see there on this on the slide the changes that are being made to the measures, and thus the changes made to the instrument that will be implemented in FY 2025. Then also the elimination of 3 measures. CMS explains in great detail the justification they provide for removing these measures, sort of a combination of it's topped out, it's not really consistent any longer with clinical evidence that supports these measures and the like. In fact, that's true across the board. And all these QRP provisions, CMS goes through a relatively lengthy explanation of why it's adding a measure, or more importantly, subtracting a measure, and its relevance going forward. And then going for FY 2026, the addition of the patient resident COVID-19 vaccination measure, that's going to be looking at the percentage of your patients that are, again, up to date with recommendations for COVID-19 vaccination.
Let's take a look at inpatient psych. And I apologize, it was not skilled nursing that had the negative adjustment for the outlier threshold. It was inpatient psych. So this too was in the August 2nd Federal Register. For those who love to read Federal Registers, it was a good day. If you want the small print version. Essentially, we are looking at an increase in our payment rates for inpatient psych of about 2.4% over the current year. This is based upon market basket increase of 3.5, less again 0.2 for productivity, and then again less 0.9 related to the change in the outlier threshold. The per diem rate is going to go up about $30 from $865 to $895. The electroconvulsive shock therapy treatment is going to go up to $385, currently about $373. You can see on the next bullet the change in the outlier threshold. We are seeing an outlier threshold going up almost $10,000 from $24,600 to $33,470. So a huge increase in that outlier threshold. That's why they had to make that adjustment to the base rate to adjust for that change there. Again, they use 2021 claims, and doing an adjustment for labor changes your labor portion of your wage index from 77.4 to 78.7. So again, depending upon whether or not you have a higher wage index greater than 1 or less than 1 as to whether or not this will impact you or how it will impact you. And just like with rehab, you can open your excluded unit anytime you want to, as long as you give your MAC at least 30-day notice.
So for the psychiatric facility quality reporting program, again, same modification to the COVID-19 healthcare personnel vaccination rate. CMS is adding to the QRP program for IPFs 3 health equity related measures. And these are going to look very familiar because these are the health equity measures that were added to the hospital IPPS, IQR, QRP, excuse me. I got too many acronyms going way too fast there. But these are the measures we saw added on the hospital side last year. And so now they're being incorporated into the inpatient psychiatric facility QRP program now. CMS is also adding the psychiatric inpatient experience survey measure. This will be voluntary reporting next year, followed by mandatory reporting in 26, excuse me. I just said that totally wrong, didn't I, Kathy? Voluntary reporting in 25, mandatory in 26 for payment adjustment 28. The
Right.
reason for the long runway on this measure is it introduces this completion of the survey, the 23-item survey to be administered to patients prior to discharge. And so adding those new processes to collect that data, which then will inform the measure, we provide that longer period of time to make those adjustments. Then also we see the elimination of 2 measures that begin with the 2025 payment determinations. So those will be in effect next year.
That 23-item survey is going to be interesting in terms of getting it completed and adding to the work needs. Skilled nursing, got 2 to go, skilled nursing and hospice. So for the skilled nursing final rule, we are looking at published in the Federal Register on August 7th. This is an interesting one because now we're looking at, for skilled nursing, the transition from a one payment methodology for skilled nursing to, and it was a per diem methodology, now to our PDPM payment methodology moving forward. So remember I said we were looking at a 3.3% market basket for inpatient acute. Now we're looking at a market basket for skilled nursing of 6.4%. So significant increase in costs according to CMS's calculations. Market basket measures your change in your overall costs. So 6.4% increase there. Going to, again, that 0.2 for productivity, sound like a broken record there. Less 2.3% for a parity adjustment. This parity adjustment essentially is equalizing payments under the new skilled nursing payment methodology to what payments would have been if we had stayed with the prior methodology. And this is the second adjustment we've had along this line. The last one was last year, that they don't expect any more. Essentially, CMS published information that said what is the expected change, and they were going to take it all in 1 year, and then they were convinced to do it over several years. Other thing that is interesting, and I think Martie, you and I have talked about this a little bit in terms of how come others don't have this, but skilled nursing prospective payment system is the only prospective payment system that we have that allows for an adjustment to the market basket if there is a forecast error from 1 year to the next. So we are that 6.4% market basket increase that they're starting with is actually made up of a 3% SNF market basket increase plus a 3.6% market basket forecast error. Don't ask me about the math on this. It's because of the other adjustments that are here. But they made an error in what they did previously. They are now coming back and they are fixing it.
So this was the argument that the hospitals were making on IPPS, is that CMS has the discretion to account for data errors. They could, because there's no adjustment, in the SNF rule, it's a purposeful adjustment to correct for a mistake previously made. The argument hospitals were making is that even though that's not in the statute itself for IPPS, CMS has the discretion to anticipate that there were errors in the data and make a correction. But very clearly, CMS did not buy that argument because this rule, the same rule, it appears, at least, Kathy, that had they applied this rule in IPPS, you would have seen an update significantly greater than what we got.
Significantly greater, yes.
So, now this is the thing to circle and explain to your congressman as to why there needs to be an adjustment in the PPS rate. In the IPPS rate, CMS always says it's a prospective payment system. You're always at risk that the payment won't be exactly right, but we don't go back and correct for prior errors, except for SNF. We go back and correct for prior errors. And so is there an argument we can make there that it just compounds the error over time, right? Because if they were 3% wrong this year, then that's our starting point next year. And so
right.
We just built that error in. And so it is cumulative year after year after year. And when you're in a period of higher inflation, it's going to become more and more significant for hospitals not being reimbursed to cover their costs.
And
okay, off my soapbox.
Well, and I think it's very interesting because when you look at the fact that the skilled nursing entities were able to get this included in the legislation that required them change from the previous methodology to the patient-driven payment method. Kind of interesting that they had the clout to get that done.
Or at least the foresight. right?
The forecast, foresight, yes, good. Finally, the one thing I wanted to mention is there were some technical changes to the ICD-10 code mapping related to the PDPM, and that code mapping is what is used to assign patients into clinical categories. So you're going to have some codes that will move a patient into a category next year that they are different than the one that they would have been moved into this year. So again, time to start looking at your patients and seeing if you were to regroup them, how they would be classified. Is this going to be a positive or a negative adjustment on your reimbursement?
So quality reporting program, again, that modification to the COVID-19 vaccination among healthcare personnel. CMS is finalizing its proposal to add 2 new measures, the discharge function score measure and the percentage of patients who are up to date on their COVID vaccinations. Again, like inpatient inpatient rehab facilities where the quality measures are really driven by the assessment, submission of the assessment data. Same is somewhat true for SNF. The driver in most cases is the submission of the MDS data, where things like the discharge functional score is calculated from that MDS data that the SNF submits. Here it is, Kathy. The one example where CMS backed down from a proposal. They had proposed to include the Core Q short stay discharge measure for SNFs, and based on commentary received from the industry, they chose to back down on this measure and back down in a pretty significant way. It wasn't like, well, we'll delay this for a while. It was basically, we're not going to finalize this because we agree with the commentators that this is not a reliable measure. So it can happen, and it did happen this year. There's an instance. They're removing 3 measures that begin in FY2025. Again, see the detail there. Importantly, CMS is changing the data completeness requirement for submission of quality reporting data, MDS data. Currently, you have to submit 100% of the required information for at least 80% of the patients you submit data on. CMS intends to increase that now to 90% beginning next year. SNF, in addition to having its very handy dandy, I made a mistake previously, now I'm going to correct it provision, also has a value-based purchasing program. So unlike the others we're going to talk about, like hospital inpatient, they have a value-based purchasing program. And as you can see, significant number of measure updates coming this year, sort of rolling between 2024 and 2027. But they are also introducing that health equity adjustment. So this is going to sound familiar to what CMS has introduced for IPPS, so that those SNFs that serve a higher percentage of dual eligible individuals will receive an adjustment upward. It's important to note here that one of the unique characteristics of the SNF value-based purchasing program, that like IPPS, it's a 2% withhold, but they only give back to the higher performing hospitals 60% of that 2%. So again, if you're poorly performing, you're going to lose your 2%, not get anything back. If you're a top performer, you're going to keep your 2%, but your bump bonus is going to be smaller because only 60% is going to be available for distribution to the top performing hospitals of that withhold. CMS, to make sure that we don't penalize anyone, that we in fact give those facilities that have high health equity adjustment scores more money without taking money away from others. In this instance, we're going to increase that withhold. Well, we're going to increase the payout percentage from 60% to 66% when we introduce the health equity adjustment in 2027. So that's good news there.
For those of us who think that we should mark August 2nd on our calendars as a great day for regs, we also got the hospice wage index and payment rate update published in the Federal Register. So with this particular one, and this is the last one for this session, folks, the final rule provides a 3.1% increase in the rates for those hospitals that do report their hospice quality reporting requirements, that meet their quality reporting requirements. The payment rate update was, again, market basket of 3.3 minus the productivity. Something very interesting, and we need to be concerned if this were to come to another provider type near and dear to you. But under the hospice program, historically, those providers who were not reporting under the quality program or not meeting the requirements had a 2% reduction. So rather than getting that 3.1% increase, they would have gotten a 1.1% increase in their rates. They are modifying this. It will now be a 4% reduction in the payment rate. So when you're looking at a 3.1% increase for those who are reporting the quality, minus 4% if you are not meeting the requirements for quality reporting, you're going to have a negative adjustment in 2024 of a negative 0.9%. So this is something we need to be concerned about if they were to decide to impose that additional penalty on other providers. This is quality reporting only. It does not get into the issue of meaningful use. For those who aren't familiar, there is a cap on the total expenditure on a per patient basis. It is capped, although it's not tied to a specific patient. It is capped in the overall payments to a hospice facility or hospice provider. We're going to see about a $1,000 increase in that cap between 2023 and 2024. And Marty?
Other important provision in the hospice final rule is the requirement that both the physicians that certify a patient is eligible for hospice, both the hospice medical director or the member of the physician team member of the hospice interdisciplinary group, they both are going to have to be enrolled in Medicare or have opted out of the program. And this is one of those program integrity requirements, because CMS believes that they have to be able to determine that physician's qualification to make that determination, and it can only make that qualification determination if in fact that physician has gone through the Medicare enrollment process. So they intend to provide that higher level of supervision of those determinations. They will begin imposing that requirement as of May 1st of 2024 to allow sufficient time for physicians to become enrolled in the program. Now let's talk about that hospice quality reporting program. And maybe the screen will move forward. There we go. As Kathy noted, significant change this year, that now we're going to be subject to a 4% penalty if we don't report. And that's important because hospices actually have the worst record on reporting of any of these provider types. That CMS reports about 18% of hospices do not meet the requirements for reporting of quality data. Now, again, the manner in which they report is different because it is tied to the hospice item set, certain information that hospices are required to submit for each patient. That information is then utilized to generate the scores on the quality measures. And the concern here is that we have a pretty high number of hospices that are not collecting that data and submitting it in a timely manner. And so this is to create the incentive for that submission of data, in part for monitoring purposes. CMS also has a long-term plan to replace the hospice item set with what they refer to as the HOPE, the Hospice Outcome and Patient Evaluation Tool. It is much more focused on a more holistic view of the hospice patient. The hospice inpatient set is very much a clinical evaluation of the patient. This is intended to provide an assessment tool across multiple needs of the patient and how the hospice is responding to them. CMS has been doing stakeholder meetings and expert opinion panels and the like on the development of the HOPE model. It's run the alpha and the beta test, but there's still no specific timeline for implementation, but certainly something that merits ongoing attention. CMS also noted in the final rule for hospices that they continue to work on the development of health equity measures specific to hospices going forward. So deep breath, Kathy. We made it through the fiscal year final rules. Certainly some significant changes. And as you said, I mean, at this point, they're final, and it's up to Congress if we're going to make any changes that are going to impact FY 2024. And I made the reference to September because effectively Congress has until the end of September to fund all of the appropriations bills, including that which impacts the Medicare program. So we will see what happens there. And certainly, I think you and I may be talking about it in a webinar coming to your computer soon, right?
Sounds like fun.
In the meantime, our next Healthcare Regulatory Roundup is scheduled for August 30th. Our colleagues Karen Anderson and Tracy Waugh will be providing an EMTALA update, enforcement activity, directives coming out of the administration, like all to be covered in that session. So hope you'll be able to join us then. Otherwise, hope you have a great day.
Take care.
Martie, Kathy, thank you so much. Later today, you'll receive an email with their contact information and a recording of this webinar. Also, these slides and recordings for every episode of PYA's Healthcare Regulatory Roundup series are available on the Insights page at PYA's website. That's pyapc.com. While you're there, you can register for other PYA webinars and learn more about the full range of services offered by PYA. Please remember to stay on the line once this webinar disconnects to complete a short survey and post any questions you may have. On behalf of PYA, thanks for joining us and have a great rest of your day.